To those that are here with us, first of all, before I start, I would like to say thank you for coming to join us to this lecture with Dr. Katz. Thank you to Dr. Katz for being with us today. It's not obvious that we are lucky to have you on 9/11. Before I tell you all about Dr. Katz, I would just like to say, for those who don't really know who we are, Tal and I started a non-profit association called Planet Therapy. We, as both therapists with therapy backgrounds, we knew this situation is not going to end in a heartbeat, and we knew what would be the outcome of it. So we just knew we had to do something about it. We started this platform bringing therapists from around the world to help those in Israel that are either affected by October 7 or still through the war. And there is a great collective trauma. We met along the way wonderful people. One of them is Dr. Katz, which we were amazed when we met on our first time. And it literally felt that I feel like I'm speaking with a big brother, and we're going to be your little sisters, because it's 20 years in advance of all this amazing stuff that you've done. And we are only here to learn and explore. And everybody, we are all with the same purpose, to heal as many people as we can. So if there are any therapists out there that haven't joined us yet, you're more than welcome. Tal is going to leave the link in the chat room. Basically, each therapist gives 2 hours per week. We don't want to overburden anybody, and everybody can do whatever they can to help those out there. If you're not a therapist and you can contribute in any other way, please enter our website and you can find there more information how everybody can contribute. So let me tell you, Dr. Katz is a global leader in the provision of mental health care to disaster-affected and low-resource communities. In '98, he co-founded the organization that coordinated the psychiatric response to 9/11 in New York City. He also started the World Trade Center mental health screening and treatment program for 9/11 response. I can go on and on and on, but I don't know if we have time. So Craig, Dr. Craig, thank you so much for being with us, and you can take it from here.
Well, thank you very much, and thank you for having me. And it is definitely meaningful to be able to do this on 9/11. I will get right to it. So I'm going to basically tell you the sort of the story about of my experience, our experience here in New York and here at Mount Sinai, addressing the long-term mental health needs, particularly of the responders down at Ground Zero, and both in the short and the long term. And then, I mean, I've given this talk several times. It was originally just a month or two after October 7th. Now, you know, October 7th is almost here now, and so it's becoming the long term, unfortunately. But I will eventually get around to, you know, my sense of the lessons for October 7th, or the comparisons, the similarities and the differences between the two, and what may be useful for thinking about things in Israel. So, Ground Zero. I mean, I doubt that I have to tell you what Ground Zero is. Here's an image of it from the 9/11 attacks. Yeah, unbelievably 23 years ago today. And these are just different images. I won't belabor them. So a lot of people rushed in to help, thankfully. And whoops. And I want to just move something out of the way here. Sorry, my Zoom bar is in the way, so I can't see everything. Okay, here we go. Yeah. So so hundreds of thousands of people. It's a very, Lower Manhattan is a very concentrated place, if you've ever been there. A lot of people are affected, both residents and local workers. And yes, as I said, tens of thousands of workers and volunteers rush in. And this is, again, another image. over the long term, this is what became a concern, and I'll get back to this, which was the so-called World Trade Center dust, and the health effects of all that. And I'll get back to that, but keep that image in mind. So the immediate aftermath of 9/11. So before 9/11, some colleagues and I founded an organization called Disaster Psychiatry Outreach, and the idea was to use psychiatrists in particular to help out after disaster. Not that we had anything against psychologists or social workers or other types of mental health professionals, but we were partnering with the American Red Cross, which I don't know if it's quite still the policy, but basically, if you're a psychiatrist and you work with the Red Cross, you couldn't prescribe. And we wanted to at least have that option, even though there's actually a lack of good data to support using medications right after someone's traumatized. So we founded our organization to complement what exists here in the States to utilize psychiatrists. And this was in response to participating in the response to an air crash in 1998, the crash of Swiss Air Flight 111, which had originated in LA. It was on its way to Paris. It stopped in JFK. And after it departed JFK, it crashed off of Nova Scotia, and there were no survivors. And we responded to that, and we we being a group of psychiatry residents from Columbia University, and we wound up being like somehow the only psychiatrist, which is surprising in a city here, which we have thousands of mental health professionals here. And we kind of got involved sort of randomly, and we decided we wanted to help out in the future, and we didn't want it to be so random. So that's why we founded our organization. And right after 9/11, there was a family assistance center set up, if you know Manhattan at all, over on Lexington Avenue, the Lexington Avenue Armory, which is usually where our National Guard practices. So big, giant space. And we were able to work there because we had been working on disaster response since before 9/11. So the city of New York knew us, and we were able to get in and start there. And then the Family Assistance Center got transferred over to Pier 94 on the other side of Manhattan on the Hudson River, like giant place that's usually used for things like this, like home design shows, but giant cavernous space. This is the interior where we literally set up our own booth, like a mental health booth, and saw people there for about 2+ months right after 9/11. We also had a chance to set up a specific center there for kids. My wife is a child psychiatrist and a pediatrician, and she helped to spearhead that. So this is for kids that were coming with their caretakers. The caretakers are coming there to the Family Assistance Center to look into benefits, initially just to see if their loved one survived, but then ultimately it was really about getting benefits and long-term needs addressed. And we set something up for kids while we were there. And this is what people look like for the first 2+ months after 9/11. We ultimately at the Family Assistance Center saw almost 850 patients. We had 268 or so volunteer psychiatrists. And before 9/11, we couldn't get anyone to volunteer with us. And now we had a flood of volunteers that we had to train very quickly and organize and credential. But not surprisingly, for the immediate aftermath of a trauma, people were having problems sleeping, joylessness, anxiety, low mood, nothing particularly surprising. But what we primarily did there was help people with their insomnia, gave them some sleep meds, and potentially referred them on for long-term services, which is what we were not there to do. And a lot of the individuals that we saw did get a diagnosis. We weren't there necessarily expecting to diagnose people, but there was a fair amount of acute stress disorder. There was some concern that we were over-diagnosing people who were just having a normal stress reaction. And we had to kind of correct how some of our psychiatrists were diagnosing people, right? Because, there's a tendency sometimes, a reflex, to call any kind of emotional reaction to a trauma PTSD, which obviously it is not the case. But there is definitely an awareness, and there's data to support this, that firstly, that recovery takes a lot longer than infrastructure rebuilding. In other words, this is a paper from JAMA, from the Journal of the American Medical Association. But their base idea was that the recovery from a disaster, a large-scale event, takes about 10 times as long as the initial rescue. And 9/11 thankfully proved to be a one-day event for us. So we were able to shift from rescue to recovery. But the point that I bring up here is that the mental health recovery is thought to take even longer than that 10 times. And it's actually hard to quantify how long it takes. And I'll give you a sense for how long it's taken here. So basically the idea is mental health recovery takes an enormously longer time than even the initial rescue and recovery response. And that's what we've lived here in New York, and particularly in terms of helping the responders. So as Alana mentioned, I work at Mount Sinai, at the Mount Sinai Hospital, at the Icahn School of Medicine at Mount Sinai. Here are some pictures. We're, on the Upper East Side. And right after 9/11, our Division of Occupational Medicine, which has been in existence for a number of decades and works with the labor unions in the city, iron workers, construction workers, on sort of day-to-day occupational health issues. They were able to very quickly ramp up and get federal funding from the US government to set up a health, what is now called, it's gone through a few names, now the World Trade Center Health Program. And their goal was to monitor for the physical health effects of being down at ground zero, or at a landfill where a lot of remains and debris were being taken to out on Staten Island. And they were focused on physical health. But our colleagues in occupational medicine said in their initial piloting of this, they would sit down with these guys, and they were largely guys, at least initially, and they were crying. And our colleagues in occupational medicine didn't feel comfortable dealing with crying men or crying patients. So they contacted us in psychiatry, and I had the background in disaster psychiatry. And from that, we set up a mental health program that became part of this program. That worked alongside of our colleagues in occupational medicine. So about 90,000 plus people are thought to have participated in the rescue and recovery efforts. These are workers, these are volunteers down at ground zero. So quite a few people. And we set up this mental health program, and I show you this basket because this is another image that means a lot to me, which is this is the initial file folder for our program. This is which I still have in my apartment, and I'll show you what became of the program. But this is where we had our first few patients come through the door, and what we did is, so we had a challenge, right? Our colleagues in occupational medicine said, we're going to be having about 40 or 50 volunteers or workers coming in every day, and they're going to get a physical health screening. They're going to get chest x-rays, blood work. They're going to meet with the doctor and get a physical exam. So how are you going to do mental health with all that? And so what we did is we set up surveys that these individuals filled out while they're in their waiting room or while they're in between all these physical health stations. Depending upon how they filled out the surveys, if they screened in on previously validated thresholds, we would see them, right? So we had the general health questionnaire, which is like general mental health, the patient health questionnaire, which includes major depression and also generalized anxiety, PTSD, we had alcohol, and we also looked at just general disability from mental health symptoms. And we had this system. Someone was called green if they didn't screen in on anything. They were yellow if they screened in, but red if they screened in and they indicated any kind of suicidality. And if they screened in on yellow or red, they were referred to us. If they were yellow and they didn't want to see us, we couldn't force them to see us. And particularly early on, this is not a mental health seeking population, right? Men, largely, if you understand the term blue collar, sort of, laborers, not the kind of usual people that knock on my door. So if they didn't want to see us, we couldn't make them see us. But if they were red, any kind of suicidality, they had to see us. We couldn't let them walk out the door. And that's how we efficiently screen people. And this is to give you just a sense from the first 1,000 people that we saw. Again, think about that little file box. We quickly outgrew that file box. So this is from the first 1,100 plus. And you could see 43% screened in. Right, so 43% of them on the day of their medical evaluation were referred to us. 8% of them had, another 8% had suicidality, so total about half. So we wind up seeing about half of initially of all the individuals that showed up for this screening program with a mental health concern. And this is just to give you this is just to depict it graphically. But for over the across the first year, we were screening in 50%, which is actually was higher than I predicted. Now, just to give you a further sense of the challenges, we initially got funding only to do screenings. We actually did not have funding for treatment. So we had a challenge, right? We're screening all these individuals, right? Thousands of people. Not all of those 50%, when we sat down with them to go through their surveys, did they actually wind up having a mental health problem, right? Because those are just paper and pencil surveys, right? So they may not be accurate. And that was the whole idea behind sitting down with one of us. But we were still meeting with a lot of people and didn't know what to do. And I have to say, the funding we originally got was not from our government. The federal government was not prepared to pay for mental health. And so we got thankfully a very generous private foundation in the city called the Robin Hood Foundation to pay. They were able to pay for the screening program. And then eventually over time, through a little bit of federal funding, and also through the Robin Hood Foundation, we were able to add in treatment to the program so that we, weren't at a loss once we identified all these problems. And we provided, a range of mental health treatment, very traditional mental health treatment. Some of it is expanded over time. This is sort of where it's at now. But, medication, individual psychotherapy, group psychotherapy. Over time, we added in psychoeducation groups because my colleagues, I didn't start them, my colleagues realized over time that for a lot of these individuals, they were so unfamiliar with mental health care that it was important to kind of teach them about mental health care, acculturate them, not just refer them for treatment and potentially even scare them off, but bring them back for some basically like classes on what is mental health, what is trauma, what is PTSD, et cetera, and then ease them into treatment. So just to give you a kind of a sense of how this flowed, we counted on funding from the Robin Hood Foundation for the first, almost through 2010. So they gave us over $6 million, and it was very stressful because we had to renew with them every year. And again, they were very good to us, but our colleagues on the occupational health side were getting all this funding from the federal government, and we were trying to keep pace with them. And again, we eventually added in some money from the federal government for treatment, although some of the funding we weren't even allowed to call it treatment because of the funding stream it was coming from. We had to call it crisis counseling. And so eventually, again, we added in some treatment, but just to give you a sense for like the trajectory of this, eventually something called the James Sedroga bill was passed here. And that is James Sedroga. He was a detective that worked down at Ground Zero. He died from, I forget what World Trade Center related health condition it was. I think it was a cancer. And this bill was named for him. And in that bill, they included mental health funding. So we were able finally to shift from stressing out about getting private funding to the government paying for it, which is, you hope that, seed money, we got quite a bit of seed money, eventually teaches your government what it should be paying for and helps them prioritize. And this bill was reauthorized in 2015. And now this program, which is still going on now, and I'll show you how big it's gotten, is now funded through 2090, right? It's a really kind of a gold standard, I think. And like we're very lucky to have this for all the individuals that were affected. So this is to give you a sense of the enrollment. There actually is updated data as of August last month, but the graphics didn't look as good. So I think these graphs will make the point. You can see the program now treats not just responders, but also survivors who are down in the World Trade Center area. But you can see as of March, we are approaching 90,000 responders, almost capturing almost all the people that were estimated to be down there. But the and you see the blue line are survivors. But one important point to make it, this graph is not just, again, if you think back to my file box, right? This is what's become of it. Now, not all these people are getting mental health care, but I'll show you more about that. But the other thing is this curve is still going up, right? So new people 23 years later are still enrolling in our program after all this time, which kind of blows my mind. But it talks about, I think it really demonstrates the need to be there for the long term if you have the resources to do that. And this is just another graph to show you. Most of the people in the program were responders of various types down at ground zero. The yellow are firefighters from the FDNY, and blue are survivors. And the green are actually folks from the Pentagon that was also attacked that day. But most of the patients in the program are construction workers, iron workers, volunteers, communications workers, all the people that were down there trying to clean up, either do the rescue efforts or try to clean up the place enough. And this, over time, there's a concept of so-called certified conditions that was developed, which is, in other words, which conditions count as related to World Trade Center. Because obviously, if you follow thousands of people over time, people are going to develop medical problems that may or may not be related to the exposure down at ground zero. And you could see there's quite a bit of upper respiratory problems, unfortunately, quite a bit of cancer, and I'll show you a little more detail on that. A lot of actually also reflux disease. The dust that I showed you greatly impacted on people's airways and also on their gastrointestinal system, the upper GI. So you see asthma, sleep problems, and there you see PTSD, and down below different forms of anxiety and major depression, right? These are the top 10. So 3 of the top 10 certified conditions as of this past March were mental health related. And this is just a graph that shows you the same thing. And just to give you a sense of the cancers, right, which is what people started to fear pretty early on about ground zero, even though the government and our Environmental Protection Agency was saying it's fine. This is what's happened over time. Skin cancers, for some reason, prostate cancers, breast cancer, many of which are thought to be related to exposure and not, something that would have occurred anyway. So, I show this because obviously October 7th, you're not dealing with an environmental exposure, right? You're dealing with an attack, but to at least be starting to think about the physical health impact, the injuries, the war, obviously the war injuries, all the physical injuries from the attacks, the sexual violence, those who survived. Kind of this would be the rough analog in 9/11 and October 7th. And at least the last number I saw, so about 20,000 plus patients have at least one mental health certification, like one mental health disorder. And at least I couldn't find this data current, but as of a year ago, less than half, somewhere between just under 50% were actually enrolled in care. So even though we have this incredible program, still only half of these folks that we're picking up are getting mental health care. And here at Mount Sinai, which is one of the largest centers, there are centers now all over the country because over time, people that lived and worked here in New York City have dispersed around the country, partly because they might have done it anyway, partly because some people wanted to not have anything to do with New York City ever again, hoping to go to a safer place that was less terrorism prone. So just to give you a sense of the size of the program, our center is the largest center. And so we have like about 25,000 patients, several hundred medical and mental health staff. And then there are people out in the community who also provide care that we're able to reimburse through the funding to treat these folks. And we also, we deal with private insurance here. The program tries to tap into that too, but most of this is again through that Zadroga bill that I mentioned. So, I mean, that's the sort of the story, the evolution of our program, at least from a mental health perspective and somewhat from a physical health perspective. So now I'll try to talk about sort of the lessons and how I see it in relation to October 7th. And no doubt you all will have impressions and opinions about that too. Um, I mean, so, from very early on, I was contacted by colleagues that I've come to know in Israel uh, because people saw a parallel between 9/11 and October 7th, both terrorist attacks. But, there, as you probably maybe more than well aware, there actually are quite a few differences. I mean, for one, 9/11 thankfully proved to be pretty much one day, one point in time, although we did have in New York City about a couple of months after we had anthrax attacks on some of our media companies. Who knows where that fits into the actual 9/11, but it was sort of part of the chaos of the time. We also had an air crash of a American Airlines flight that was, I think it was on its way to the Dominican Republic. So we had a lot of things going on at the time, but it was still 9/11. We didn't know at the time, but proved to be one day. We Also, New York City at the time was, I guess I would say, not a politically tense place, as opposed to Israel, which, pre-October 7th, obviously, and it seems like it's still going on. There was obviously a lot of political discord, I think, over the government, and you all know this better than I do, but about the Supreme Court and all that, right? So it was I think, from what I can see, a pretty fraught time in civil society in Israel before, and there was also the pandemic before, right? And so, 9/11, we had none of that, which is not to say there weren't plenty of parts of New York City, in particular, where people live in, incredible poverty and amid violence, et cetera. But on the whole, the city was doing pretty well at the time, and not emerging from a pandemic. Also, right, America, we are not surrounded by our enemies. We have drug cartels in Mexico. That would be really the closest thing to enemies on our border, but it's obviously not the same. And of course, the war that came out of 9/11 happened on the other side of the earth. Yes, it was with our soldiers, but in terms of the direct effect on day-to-day life, particularly in a place like New York, where we're not a military city, like a place like San Antonio in Texas is, I think, called I think Military Town USA, right? They have a lot of military bases. New York is not at all like that. So there are, I think, a lot of differences between October 7th and 9/11, and for that matter, New York and Israel. And I think there are two particular issues that I didn't really appreciate when I gave this talk early on, a few months after October 7th. But I think there are really two issues that really make October 7th so much more different than 9/11. One is the sexual violence that was perpetrated that day. But I think more than anything else are the hostages. It just, I don't think I have to tell you this, but it's pretty clear that the hostage situation weighs on Israel and Israelis in a way that they're just, it just multiplies I think the mental health impact, the psychological impact, in a way that we did not have to deal with 9/11. And I think there is a saying that if you've seen one disaster, you've seen one disaster. And I think everyone is different, and that is certainly different between the two of them. But to get back to the mental health services, I think the part of what I would call the magical ingredient in what we were able to do, the reason we were able to see so many, thousands of individuals, is because we co-located mental health with medical services. I'm pretty sure that if we had set up mental health by itself, on its own someplace, I know we would never have gotten the foot traffic that we did. And so being, and keep in mind that at least early on, the individuals that were coming to our program were coming because of medical concerns. Yeah, I'm sure maybe a few of them had mental health concerns, but they were worried about the World Trade Center cough or cancer. And so that's what they were coming for. They weren't coming for mental health. We, to some sense, kind of grabbed them while they were in the waiting room. And so, I think, if we had done something like Lucy, I think our chair would have been empty as well. So I really think that that was like the key, that has been the key thing, right? The program is still going on now. I haven't run it for a number of years now, but it is still going on. And that was the essential. Now, I have to say early on, we also did not call ourselves mental health professionals. We called ourselves counselors because there was so much stigma in this population. And again, we were trying to, because they weren't coming to see us, we sort of had to, we felt and we were advised to sort of tone down that we were psychiatrists and psychologists and social workers. So originally we called ourselves counselors, but over time, and I find this to be the case with mental health, I do, I think as it was in the introduction, I do global health work around the world in places that don't know much at all about psychiatry, don't really have resources. If you set up mental health care and people start getting better, they will keep coming, right? The results matter. So over time, we were able to kind of out ourselves as psychiatrists and psychologists and have it be just fine and have people come. And people start recommending that one another to you, other people in the unions, other people in the workplace, and sending them to us. So I think that's like by far, I think the most important thing that we were able to do, and that I feel we learned, is that integration. But other implications, I think private funding, I think, is key. And I think I've talked with Alana and Tal about this separately, right? But private funding is really important until government funding becomes available. I think, again, we were able to demonstrate, thankfully, due to private foundations, to the government, that their initial idea, which was basically just to have like one depression screening survey as part of the physical health rotations that they were doing when they came here, was not going to be enough. So I think that's one implication for October 7th. And it has seemed to me that so far, from what I can tell, has been the case in Israel. I think that there has been some expansion, I think, in government funding and allocations for treatment through the HMOs, but it's certainly not enough. And I think there's been a lot of philanthropy that sort of had to fill in the cracks for now. Although I have to say that the Ministry of Health seemed quite attuned from very, very early on that they needed to address mental health in a way that I thought was quicker than the US government after 9/11. I think another implication is, and kind of said this earlier, is be prepared for the long term. When I wrote the first grant for the screening, the mental health screening program, it was going to be a 1-year grant. But here we are 23 years later, and the program is still going, right? And as I showed you in that graph, new people are still coming in. And now over time, it certainly becomes harder and harder to separate out, what is trauma related from 23 years later, and what's the impact of life that happens in between. And the stresses of life, or just people's natural biology, that mental health conditions emerge. But what we've wound up becoming is just like a mental health program for a population that never would have gotten mental health to begin with, if not for 9/11, and mental health care, that is. Because also the people that are most likely, typically, or amongst the most likely to have the mental health impact from a large-scale trauma or any trauma, are people with prior mental health problems, particularly undiagnosed or untreated mental health problems. So when you set up some kind of a program in response to a massive event like October 7th, you're going to wind up picking up problems from before, right? So not for everybody. Sometimes the trauma alone, people's lives might have been fine before. They might have no mental health conditions, no family history of mental health problems. But for the most part, it becomes an event like 9/11 or October 7th exposes problems that existed before in individuals and in the system, right? So, what I've come to learn, I'd only been to Israel for family vacation once before October 7th. So, I'm learning on the fly, and any of you can correct me, but what I've come to learn is that the mental health system in Israel pre-October 7th was completely overwhelmed and like months-long waits to get an appointment. And so then along comes an event like this that's going to drive up the need, and it just exposes that even more, right? So you have to be prepared for the long term. You have to also hope that it's an opportunity. I might have this on another slide to actually improve your mental health system. I mean, that's what we did for these 9/11 responders. Their health and mental health system, health and mental health care greatly improved because of 9/11. Obviously, access to services, I should say, right? Even though they also, it was at the cost of having a 9/11 related health and or mental health problem. Um, so, these events hopefully draw in resources eventually enough to make things better than they were before, right? Something that you would call sort of, build back better would be the idea. And we can hope that for the mental health system in Israel, that that's the case, at least if not now, then down the road. Another, I think, implication is the value of social support. Um, I, um, so yes, I've done disaster response in different places. These are images from Japan's 3/11 triple disaster, which you may recall was a earthquake, tsunami, and then a nuclear disaster in the northeastern part of the Tohoku region of Japan. And we had a chance to help there in different ways. Um, this is uh, this is a you may know the crane, particularly origami cranes, are a symbol of peace. And on 9/11, after 9/11, Japan sent all these little miniature cranes, origami cranes, to New York City as a source of support. 9/11 survivors took some of the World Trade Center steel and made this crane and brought it back to Japan. And I went with them, right? So this is steel from the World Trade Center made into a crane, and we returned it to Japan. And I show all this. This is us visiting people that were displaced by the tsunami in Fukushima, living in temporary housing. And this is a parallel with October 7th too, in terms of how many people have been displaced from the north and south, right? I think to the center. But what we did is we brought the crane, but we actually brought 9/11 survivors to Japan to share what it was like for them to cope and recover from 9/11. And I'm sure many of them are downtown today at giving tours, because many of them are docents at the 9/11 Museum. So that's us mixed in with local Japanese there. And just the idea is that social support can go a long way. There's lots of evidence that you don't always need fancy psychiatry services to help people recover. And I think I left out, okay, yeah, I had another slide about this. So I actually think part of our 9/11 program that works is that it involves people from unions that have a shared identity. And so you get them together and they connect. And for a while we did have peer support groups where they were supporting one another. And certainly, when you think about all the different populations in Israel that were affected by October 7th, obviously soldiers, Nova survivors, right? Families of soldiers, right? People who were displaced, the grieved, or you can think of so many different subpopulations. But I think establishing some kind of support amongst themselves, not just including mental health, I think is important. And actually, when I spoke to the Ministry of Health very early on, I suggested doing like a buddy system where you connect people, which we did after the pandemic here at our hospital, where you pair up people from a similar group to be checking in on one another. But anyway, so that's about peer support, not about fancy mental health care. The other thing in the long term is to prepare for the multiplicity of needs, right? So our program dealt with medical needs, but has dealt with medical needs, but also socioeconomic, right? So many of our uh, rescue and recovery workers could not go back to work because of their physical or mental health uh, conditions. And so you we wound up having to provide benefits to them, disability benefits. And from what I can tell, I think the analog October 7th would certainly be IDF soldiers, who are injured and may not be able to go back to their prior vocation. At the least, that to me is the comparable analog. So one has to be thinking about that. And also um, when you're thinking about like how many people might be affected in Israel, right? There are going to be higher risk populations. And that was really what our 9/11 program was about. The reason we got funding is because we were able to say to the Robin Hood Foundation, these rescue and recovery workers are a high risk population because of what they did, what they saw. And so they were considered a highly vulnerable population, probably more vulnerable because they were underserved from a mental health perspective to begin with. Who would be the most vulnerable populations in Israel where you might be, prioritizing besides, the IDF? Well, it might be people who, obviously people who lost loved ones on October 7th, people who were physically injured on October 7th. You may consider those who are displaced. There are different ways to kind of layer it, and theoretically, prioritize when you can't necessarily address everyone all at once. So, I think that is another way to think about what could otherwise be a pretty overwhelming situation. And that's what this picture gets at. There's this idea of, once an event happens, there's a disaster community. And at the center of the community are the people who are directly affected, whether it's, people in the kibbutz, the moshavs, at Nova, the Nova Festival, right? And then you have all these different rings of people that emanate out from that center, that the center of the trauma, right? The family members of those who are directly affected or the bereaved, and then all the people who are providing services. I guess in October 7th analog, the service, you call it service providers, it would be the soldiers who now are have been in Gaza, etc. And then the support providers, which would be us, for example. Although this is quite fluid, because if you think about this concept for COVID-19, for example, the support providers, like the healthcare providers, are closer to the center because we were directly exposed. In any case, this is just as a sort of reminder of, I talked about the risk, I mean, that image is about the exposure, like how exposed you were to October 7th or 9/11. But this is all the stuff that we bring to the event on October 6th or on September 10th, right? Besides the initial dose of trauma, how much trauma you had before, what your psych history was before, what your life was like before, and how many supports you had before or after the event, right? There are all these different factors that go into figuring out who's most at risk. So you can prioritize who you're going to see, not just based on where they are in that diagram, how close they were to October 7th, on October 7th, or to the war, but also, what they were like before, what their lives were like before.